in the next 15 minutes, we are going to discuss about, well, I will call it a hot topic, of course, the effect of hyperthermia on neurological injury. I do not have any conflict of interest, as we are going to discuss about some devices, so I want this to be actually very clear. So every time I'm asked to give a talk somewhere, the first thing which comes into my mind is actually whether this is really important or not, and which is the evidence that we have so far regarding this topic. And so the first thing that I generally do is to go on PubMed, and I've done it even this time, and if you try to type fever and brain, this is actually what you can find. So a lot of papers which are basically divided in different brain injured patients, so starting from the stroke patients, which are actually the most representative, and going through traumatic brain injury and subarachnoidal hemorrhage, and we'll go through the different pathologies because the pathophysiology is slightly different according to this. But the problem is that despite there are a large number of papers, there are not very strong evidence. And because there are not strong evidence, most of the time we have to rely on our clinical experience, on our institutional protocols, consensus papers like this one, which has been just published a few months ago, which is a consensus paper of experts from the UK. And sometimes even surveys, and one of these has just been published recently from Edoardo Piccetti, and we will discuss it in a second. So, because of this, there are a lot of questions which are still pending, and I have to tell you that I do not have the answers for all these questions, but basically what is still pending in terms of fever and neurocritical care is whether we should treat it as a prophylactic treatment or just when the symptoms come out, for example, in which patients. So do we have to treat all the patients, or do we have to do a sort of selection? Which is the fever burden? I know that it might seem a very simplistic question, but it's actually a huge problem. Which are the modes of monitoring, how we treat them, and basically for how long? So lots of questions. I will start to discuss with you about the things that we know very well. And the thing that we know very well is that fever after a brain injury is very, very common. If you have a look at this data, basically fever which occurs within the first 2 weeks of admission in neurocritical care occurs in the 34% of the patients, a lot of patients, infectious and not infectious in the 9% of the patients. So we need to keep in our mind that fever is not just infection. Fever is a symptom. So the first thing that we need to do is to make a diagnosis. And the first question, the first differential diagnosis is whether we are in front of a problem with infection or we are in front of a neurogenic fever, especially in neurocritical care. So, as you can see, although most of the patients, even in neurocritical care, have fever because of infection reasons, there is a huge amount of patients who develop fever, and it's called unexplained or unknown reasons. And it's important to make this differential diagnosis because the pathophysiology and, of course, the treatment and the management of a patient is definitely different in these two kind of patients. So, on your left, there is the pathophysiological mechanism on the basis of the infection one. On the right, the pathophysiological mechanism of a neurogenic fever, which is actually correlated with the primary brain injury, the release of cytokines, and the direct effect on the hypothalamus, which is basically responsible for the synthesization of the prostaglandin E2. So at the end, what happens is that there is an upward shift of a time set point and the temperature elevation. So, because we need to talk about pathophysiology and we need to talk about the things that we do know about hyperthermia, that's actually what we are sure about. We know that hyperthermia is harmful for the brain of the patients. So what does this mean? These are basically the conclusions from a very interesting paper which was published many years ago on stroke, and which basically explain the mechanism through which hyperthermia determines secondary brain injury. So there are several mechanisms, several pathways including the increased release of neurotransmitters, the production of oxygen radical, and ischemia-induced blood-brain barrier, as well as an increase of a metabolism, so with a depletion basically of energetic substrate. And we will see it basically in a minute. And results from experimental model, this is a model of rats, are pretty clear. So this is a model of rats with a reversible MCA occlusion, so with brain infarction, and not global but localized cerebral ischemia. And what happens in this experimental model is that when we increase the temperature from 36 to 37 degrees, even for a very small number of hours, even for just 2 hours, basically what happens is that we have an increase of a perilesional area of 3 folds, which is basically a lot. So which are the clinical implications? The translation of these experimental studies are that fever is associated with higher mortality. This is a very nice meta-analysis which included 39 studies. A lot of patients, although the methodology was absolutely strict, so very precise in terms of the results. And as you can see here, there is a strict correlation between the outcome of the patients and the higher body temperature. And when I talk about the outcome, I'm not just talking about the mortality, which is anyway increase of 1.5 as relative risk, but I'm talking also about the neurological outcome. Here it's been described as GOS, ranking, etc., and also the ICU length of stay, while the relative risk is increased up to 3 times. And why is that? Because when we are in front of the patient and we see that his intracranial pressure increases, and it's probably related to the hyperthermia, that's where we need to target our therapy. So hyperthermia determines an increase of intracranial pressure, and the pathophysiological mechanism is actually determined by 2 pathways. The first one is when we still have a coupling between cerebral blood flow and metabolism. So an increase of a cerebral metabolism determines vasodilation, increase of a cerebral blood flow, and therefore of the volume, and increased ICP. But on the other hand, we can just have an increase of a cerebral metabolism with a reduction of a cerebral blood flow, ischemia, and ICP. So in both cases, at the end, ICP is increased. But what about the biochemistry? So this is a very nice paper from the group of Milan, Nino Stocchetti, a few years ago, included 18 patients, and they were monitored with microdialysis and PbO2. And basically, these are his results. So if we increase the temperature, the core temperature from 38 to 39 degrees, this is actually what happens. There is an increase of the cerebral metabolism and oxygen extraction. So if you see the significant reduction of AgO2, which is the difference between the arterial and the jugular oxygen. So the PbO2, which is basically the result of the liver and of the metabolism, remains the same, and as a consequence of this, the biochemistry is not completely alterated. What does it mean? It means that as long as we have still the substrate, in this case the oxygen, possibly the biochemistry still has acceptable values, but there is a price to pay, which is the vasodilation and the increase of ICP. So there is no way for us to leave our patients without any treatment when they have hyperthermia. And this is extremely important, especially in patients with subarachnoidal hemorrhage, where have a look at the prevalence of fever is from the 40% to the 72%. Nearly all of the patients should be treated and monitored at least and to check the temperature. And as you can see, even in this group of patients, fever is a strong predictor of poor neurological status and mortality. At the point that if we have a look at all the medical complications which are correlated with the outcome in subarachnoidal hemorrhage, fever is the most dangerous, and it's even more dangerous, for example, than the hypotension, the metabolic disturbances, respiratory failure, hypoxia, a lot of other components that probably, when we see in the patients, we treat more aggressively rather than the temperature. So this means that probably our therapeutic targets should consider as first line the treatment of hyperthermia as well. Also because in this group of patients it is also associated with delayed cerebral ischemia, and it's actually again one of the causes of temperature greater than 38, which is associated with increase of a cerebral infarct. Good, now we basically discussed about all the things that we are sure about, but now we need to talk about the management and especially say that honestly there are not specific guidelines, and basically there are not specific guidelines even in very basic concepts, starting with when to start the treatment of a patient with hyperthermia. So what do we consider when we see a patient with increased temperature? So the definition of the American College of Critical Care Medicine and Infectious Disease Society of America says that we should call fever a temperature which is higher than 38.3. But if we go through the expert consensus that I showed you before, which was published a few months ago on BJA, all the experts said that basically they will treat the temperature when it's at around 37.5. And the results from the survey that I was mentioning before are actually telling us that they use even other different thresholds, 37.5, 38, or maybe in some cases they use lower threshold like 37, 37.5, according to the characteristic of the patients and according to the clinical situation. So there is not a consensus basically. And it also depends, in my opinion, from where you measure the temperature and for basically the instruments that you have at disposition. I give an example. There is a very important difference between the temperature of a core and the temperature of the brain. Now I understand that most of the centers, or at least many centers, do not have available the possibility to measure continuously the brain temperature. But what we need to keep in our mind is that the brain is a bit hotter, is a bit warmer than the core temperature. And this is what we need to consider. So if you have a look at this graph, basically there is a difference of at least 0.5 centigrade, which is basically already a lot if we consider the different threshold. But if you see the effects on the intracranial pressure, the effect on the ICP is mainly related to the brain temperature and not to the core temperature. So probably the difference between this consensus in the expert and the differences between different institutions is probably related also to this consideration. So if I have to tell you basically what's my opinion is that probably the threshold should be individualized, and I will treat the fever every time I suspect that this could determine a secondary brain damage. And this is not a rule for all the patients and should be considered case by case, considering clinical examination, neuromonitoring, and neuroimaging. Then we come at the last but very important point, which is how do we treat the fever? And here again, we are in a sort of trouble because there are not very clear indications. We do have many options, like the drugs, automated methods, surface or intravascular, or non-automated methods like blankets with circulating cold fluid of air. The drugs. So we do have many options, and one probably of the first line and most used drug is the paracetamol. So this is a nice study which has been published many years ago, but still very important and basically demonstrate. So the first aim was to demonstrate whether paracetamol was had a stronger efficacy compared to acetyl salicylic acid. And basically the first aim was at positive results. So yes, it does have a major effect compared to acetyl salicylic acid. But the problem is that this has an effect which is not lasting in time. It's just about 1 hour. But if you see the result at 3 hours, the two agents have basically similar effects. But the last part, the last sentence of this slide is probably the more worrying, because what we see here is that the normothermia was achieved in less than half of these patients. So basically, it's a possibility. We can use it, but it's not probably the definitive agent. Also, we need to consider that, as Eduardo Piccetti has shown in this paper, paracetamol can determine a reduction in terms of CPP and mean arterial blood pressure. I go very quickly to mention that a second line option is basically the diclofenac, and the effect on the hemodynamic component of the diclofenac are actually related mostly on the dose and the administration route. In this paper, for example, a bolus of intramuscular could determine an increase of a decrease in the map of the CPP, but in this other paper, which is a small randomized controlled trial from the group of Monza, basically what they demonstrated is that the use of low dose of the diclofenac in infusion compared with the bolus is actually safe. And if you see the results here, you have basically a good control of the temperature on the upper panel, and there are not contraindications or side effects in terms of hypotension or adverse effect associated with diclofenac. So this could be actually a more reliable option. And when this is not enough, we can use the cooling methods. There are several cooling methods that are all showed here. This is a randomized control trial, which basically compared all the technique one to each other. There is not probably an ideal method, but what we know is that basically in terms of efficacy and speed in the reduction of the temperature, except the cold packs and except the air circulating system, the others have a very good efficacy. And when we talk about the efficacy in the maintenance of the target temperature, the best option is probably the intravascular cooling system, although they have other considerations that should be considered in terms of management and side effects. And again, these are the results. These are the very last slides from the survey published a few months ago. And again, first line in terms of cooling system were the ice packs, and second line therapies were actually considered the intravenous infusion with cold fluids. And again, here it could be good point of discussion because these are patients who are already at risk of pulmonary edema, and we need to be very careful about the intake of the liquids. So these are the conclusions. The temperatures should be monitored very frequently, possibly in a continuously way. We should consider that fever could be even not infection. Questions remains about the threshold, the time of the treatment, and the use of prophylactic agent to avoid secondary injury, to avoid hyperthermia. In terms of the drugs that we have available, I will say that they do have a medium-low efficacy. The first line remains at the moment, according to surveys and consensus, the use of acetaminophen and eventually diclofenac. Pay attention, please, to the way, the rate, and the dose of the infusion, because this could be actually related to side effects. And regarding the cooling method, basically, the evidence say that there is a poor efficacy in terms of the use of the fanning, evaporative cooling. Probably it's better the use of surface cooling, which have a better control of the temperature. And of course, the use of intravascular catheter has a good efficacy, but should be limited in this case where the hyperthermia is refractory. So the question remains, and it's basically what I was mentioning before, whether in terms of threshold, etc., we should consider the patient as an individual, so if one size does not fit all, in terms of treatment, management, and monitoring. Thanks.
Thanks very much. Great, thanks very much. Maybe we'll move to our questions on the floor here.
Sorry, Elvin Thomas from the UK again. While the best evidence we have is what we believe or what we think.
Exactly.
Yeah? And I know most of those guys, and I'd have a drink with them, and that's okay. Lots of other people. We talked about here where we have a primary brain injury due to trauma, infarcts, bleed, and then subsequently developed a temperature. And we believe that keeping the temperature normal is a good thing. There are colleagues who produce guidance from the infection world where you have meningitis and encephalitis, which are infectious, who say do not reduce the temperature because that worsens outcome when the primary problem is intracranial infection. Your thoughts, please.
Yes. Well, it's slightly different. I didn't actually consider and talk about meningitis or encephalitis, etc. I just took in consideration a brain where there is a lesion and where there is a perilesional area. So there, I think, should be focused our attention, and there is the moment when we need to treat these patients very aggressively. In other situations, we could potentially observe, take time, have a think, talk to the infection disease, to the infection control, consider every other option. But in these kind of patients, it's pretty clear that even in 1-2 hours, the primary damage is incredibly increased.
Oh, yep, another question, thanks.
Again, from Cleveland Clinic. So, I mean, that temperature cutoff. So, I was in main campus in Cleveland, Ohio, and then I went to Abu Dhabi. So there, it's half European, rest of the world, and a little bit of U.S. versus North America's pure U.S. practice. So what you showed over there in the U.S., what we do is 38.3 religiously. I went there and started seeing nurses giving 37.5, 38. And to me, it's like I freaked out. So, I mean, the amount of treatment that you give, if you consider low cutoff, should be high. And we talked yesterday in a great the session about TTM. I mean, cooling people and shivering and all that. You guys have more experience in terms of that low cutoff. I mean, how much of treatment do you? Yeah, how much treatment do you give? Are you having to? Do you see yourself cooling a lot of patients? And that causes shivering, and then, so let's say you target 37.5, then what if you're masking a real infection in day 2 and day 3? Because we know neurogenic fever can continue forever and ever. So what's your experience? And
so it's very difficult to treat. And in my experience, I would say that it really depends case by case. There are cases where I generally start with the drugs, but I don't give it too much time because evidence and actually the clinical practice say that probably a more aggressive behavior is probably better and more reliable. We do cool just in a very acute phase when we have problem with the intracranial pressure. I think that if you are asking me which is the target according to this consensus and my clinical practice, in general, I would say from 36.5 to 37 at maximum, but it's not true because at the end, my target is probably the neuromonitoring and the clinical assessment of the patient. And if I think that he actually needs a lower temperature, I will go for it. The answer is probably multimodal neuromonitoring.
Great, thanks. I think in the interest of time, we'll move on.